Leena began her education at the university here for her residence committee. Is that right? She's academically accomplished, having presented APA on more than fusion. She's presented in the community and to her peers, and she's has publications. She's going to present today on gender dysphoria, which is a timely topic given the current political environment. And I'm excited to hear what you have to say.
Right. Thank you for the introduction, Dr. Casey, and joining Grand Rounds today. I will be presenting an overview of gender dysphoria. I want to say that I don't have any conflicts to disclose, and all the images I used are public domain images or otherwise credited. So I'd like to start by going over some terminology. So what is gender? According to Merriam-Webster, the dictionary, the term gender used to be used solely to denote a grammatical subclass. In the 15th century, the term gender expanded from this use to join the term sex in referring to either of the two primary biological forms of a species. This is a meaning that the word sex has had since the 14th century. In the 20th century, the term gender gained another meaning, referring to the behavioral, cultural, or psychological traits typically associated with one sex. This is what we think of today as gender role. Later in the 20th century, the word gender also came to be used in two related terms. These are gender identity, which is a person's internal sense of being male, female, or another gender, and gender expression, which is the physical and behavioral manifestation of gender identity. By the end of the 20th century, the word gender by itself was being used as a synonym for gender identity. The APA currently states that gender is comprised of one's gender identity and one's gender expression. I'd like to clarify the difference between gender and sex. Sex is the biological and physiological characteristics that define males and females. So for instance, chromosomes, reproductive organs. Sex is a biological category, whereas gender is the culturally shaped expression of sexual difference. Aspects of sex will not vary substantially between human cultures, but aspects of gender may vary greatly between cultures. In most people, sex is consistent with their gender identity. In a small minority of people, it's not. Additionally, someone may have intermediate or conflicting sex characteristics. This can be seen in those who are intersex. Intersex is a term that describes people born with sex characteristics, including chromosomes, gonads, for instance, that do not fit typical binary notions of male or female. Sex characteristics may be between male and female, or they might have separate traits of each sex. Intersexuality can occur both due to genetic and environmental factors and has been seen in various organisms. This term is not to be confused with hermaphrodite, which is a sexually reproducing organism that produces both male and female gametes. Examples of hermaphrodites are snails, starfish, and banana slugs. These animals can self-fertilize. Disorders or differences in sexual development are conditions in which sex varies in some way from the standard male or female sex. Historically, intersex babies were often subjected to early surgical procedures and committed to a male or female assignment. Recently, these practices have largely changed so that more intersex people are able to make decisions about their future and how they want to live. The DSM-5 criteria for gender dysphoria were revised to allow the diagnosis to be given to people with disorders of sexual development. A specifier is used if the gender dysphoria is associated with such a condition. So some history about the concept of gender and sex. Margaret Mead, who is pictured here, was an anthropologist who observed cultures in Polynesia. In the 1930s, she published Sex and Temperament in 3 Primitive Societies. She saw that gender role expectations in the United States were not the same as gender role expectations in other places. She saw that Western gender roles were sometimes reversed in some Polynesian cultures, and she concluded that nurture is more important than nature in producing gender. She postulated that cultural differences rather than biology determined gender differences. Dr. John Money was a sexologist at Johns Hopkins who coined the terms gender role and sexual orientation. Robert Stoller coined the term gender identity. Most societies have binary gender categories in which people are categorized as man or woman. There are some societies in which additional gender categories have existed for a long time. The Native Americans, known as the Mojave, recognize 4 genders: a woman who acts like a man, and a man who acts like a woman. Two-spirit is the term chosen by Native American and First Nations people to denote a gender category that combines aspects of both femininity and masculinity, and it is considered a 3rd gender. Although some two-spirit people are born intersex, many are born biologically as one sex or the other, but adopt a 3rd gender. Other examples of other gender categories can be found in Samoa and Mexico. I'm highlighting these to show that non-binary gender is quite cross-cultural and has occurred for centuries or longer. So in Samoa, there are 4 recognized cultural genders: female, male, fa'afafine, and fa'afatama. These are fluid gender roles that move between female and male worlds. And it is estimated that 1 to 5% of Samoans identify as one of these additional gender categories. Similarly, in Mexico, in the Zapotec group, there's a 3rd gender called the Muxes. These are people born as male who exhibit typically female behavior and are considered a 3rd gender. So back to some terminology. Gender nonconformity is not the same thing as gender dysphoria and does not always lead to dysphoria. Gender variance or gender nonconformity is behavior or expression by a person that doesn't match masculine or feminine norms. A gender nonconforming person might be transgender or non-binary or genderqueer, or they might be cisgender. So more terminology. Transsexual refers to someone who has undergone some kind of medical or surgical gender-affirming treatment. This was historically called sex reassignment. Some transsexual people might identify as transgender, although many primarily identify as the gender to which they have transitioned. People who identify as transgender but who do not seek medical or surgical treatment are not transsexual. Transvestite is somewhat an outdated term, but I want to include it because we do hear this term often, and I wanted to clarify its meaning. So transvestite is a person who dresses in clothes primarily associated with the other sex. Typically, this is used to describe a woman dressing like a man. While the term is considered outdated and the term cross-dresser seen as more appropriate, many have reclaimed the term transvestite. Transvestic disorder is in the DSM-5 section on paraphilic disorders. It requires at least 6 months of recurrent and intense sexual arousal from cross-dressing that causes clinically significant distress or impairment. Cross-dressing does not equate to gender dysphoria. Many people who cross-dress do so while retaining a gender identity that matches their assigned gender. However, a person could be diagnosed with both gender dysphoria and transvestic disorder. Many simply like to dress in the fashion typical of stereotypical females, but it doesn't cause them distress or impairment, so they don't have a disorder. So as I said, it's more common in males, rarely diagnosed in females, and this is perhaps in part because it's more acceptable for women to dress as a man, but not vice versa. So transgender is an umbrella term describing individuals whose gender identity or gender expression differs from the sex or gender assigned at birth. Some people who use this term do not consider themselves as matching a binary gender category of either strictly male or female. In addition, new terms such as gender queer, bigendered, and agendered are increasingly in use. Being transgender is distinct from sexual orientation. And transgender people may be heterosexual, homosexual, bisexual, asexual. Not all transgender people suffer from gender dysphoria. So this brings us to gender dysphoria. Gender dysphoria is distress arising from an incongruence between a person's felt gender and assigned sex at birth. That's the cardinal symptom of gender dysphoria. People with gender dysphoria commonly identify as transgender, but not all transgender individuals have gender dysphoria. That is, they may not experience the distress that is required for the diagnosis. And gender dysphoria is not related to sexual orientation, though historically gender dysphoria and sexual orientation were conflated. There are too many words on this slide, but this is the diagnostic criteria for gender dysphoria in adolescents and adults, according to the DSM-5. So I did want to include all of the criteria. In order to meet criteria for diagnosis, the patient has to have at least 2 of the following symptoms for at least 6 months, and it must cause clinically significant distress and or impairment. So they have to have a marked incongruence between one's experienced and assigned genders, a strong desire to be rid of one's primary and or secondary sexual characteristics because of this incongruence, strong desire for the characteristics of the other gender, strong desire to be the other gender, strong desire to be treated as the other gender, and a strong conviction that one has the typical feelings and reactions of the other gender or some other gender different from your assigned gender. There are different diagnostic criteria for children. This is for those who experience gender dysphoria before puberty. Puberty starts at Tanner stage 2. The average age for girls to start puberty is 11, while for boys, the average age is 12. There is a range for that. It's normal for puberty to begin at any point between the ages of 8 and 13 in girls and 9 and 14 in boys. So this is the child criteria. And in order for the child to meet criteria, they have to have this significant distress for 6 months and have met these criteria. It's similar to the adult, but it's sort of geared towards children. For example, strong preference for toys, games, and activities stereotypically used or engaged in by the other gender, strong preference for playmates of the other gender, strong rejection of toys, games, and activities typical of their assigned gender. In the DSM-5, the presence of gender variance is not the pathology. The DSM-5 states that gender nonconformity is not in itself a mental disorder. The DSM-5 moved gender dysphoria out of the sexual disorders category and into a category of its own. And as we said earlier, it allows for the diagnosis to be given to those with disorders of sexual development. The DSM-5 also includes an optional post-transition specifier to indicate when a particular person's transition is complete. And in this post-transition scenario, the diagnosis of gender dysphoria may not apply any longer because they may not be dysphoric since they've transitioned, but it does exist so that these people can get ongoing medical care, like ongoing hormonal treatment. The ICD has diagnoses and codes related to gender dysphoria as well. I wanted to include them as well. Their codes do not require significant distress or impairment. So I want to briefly review some history of the diagnosis. Gender dysphoria has probably existed throughout history, but in 1864, Karl Ulrichs, a German writer and philosopher, first described the idea of a female psyche caught in a male body. Magnus Hirschfeld is credited as among the first physicians to distinguish between homosexuality and transsexualism. And in 1949, David Caldwell proposed one of the earliest diagnostic conceptualizations with the term psychopathia transsexualis. Caldwell distinguished between biological sex and psychological sex and saw the latter as determined by social conditioning. Christine Jorgensen, who is pictured here, was the first person to become widely known in the United States for having sex reassignment surgery. She was treated in Denmark and was also a patient of Dr. Harry Benjamin, who described transsexualism in the 50s and 60s. He was a pioneer in providing treatment and laid the foundation for the World Professional Association for Transgender Health. So the first two editions of the DSM did not mention gender identity. In 1980, with the DSM-3, the diagnosis transsexualism first appeared. In 1990, the World Health Organization included this in the ICD-10. With the DSM-4 in 1994, transsexualism was replaced with gender identity disorder in adults and adolescents to reduce stigma. And with the DSM-5 in 2013, gender identity disorder was replaced with gender dysphoria. The gender dysphoria diagnosis may function as a double-edged sword. It does provide an avenue for treatment and it allows people to get care, but it also has the potential to stigmatize people by categorize them as mentally ill. So some people do feel stigmatized, but other opinion on this is that they feel validated by the diagnosis. So when does gender identity develop? By age 2, most children can identify differences between boys and girls. By age 3, most children can identify themselves as a boy or girl. This term may or may not match their assigned sex at birth. At age 3 to 5, most children have determined their gender identity. However, some may alternate between presenting themselves as a boy or girl. At 5 to 7, you have gender constancy. In the 60s, psychologist Lawrence Kohlberg outlined 3 stages that children achieve to have gender constancy. He said that the first stage is at 2 to 3 when a child has some basic awareness that they're either boys or girls. And the second stage, gender stability, is the recognition that gender is stable over time, but not necessarily in situations. For instance, they may think that if a boy wears a dress, he becomes a girl. This you may see at 3 to 5. And the third stage, gender constancy, refers to the understanding that gender is consistent over time and situations. And this you would usually see at 5 to 7. So when does gender dysphoria develop? Gender dysphoria can occur at any age after gender identity is developed. Recent findings suggest that gender dysphoria typically manifests in early childhood. Usually it persists untreated for many years before people start transition. For those who present with gender dysphoria later in life, they often report having secretly hidden their gender dysphoric feelings from others when they were younger. There was a study done in which self-report data from 155 transgender women and 55 men showed that 78% of men and 73% of women experienced gender dysphoria for the first time between ages 3 and 7. This is just one study done at Cedars-Sinai recently. There isn't a lot of data about this, but this seems to suggest that gender dysphoria occurs quite early, even though you might present later. Federal and state population studies from 2016 estimate that 1.4 to 1.65 million US adults, which is about 0.6 to 0.7% of the US population, identify as transgender. In the Netherlands, where a lot of data about gender dysphoria comes from, 0.6% of men and 0.2% of women reported incongruent gender identity and a desire to undergo sex reassignment. I've seen studies with estimates of the prevalence of gender dysphoria in children, adolescents, and adults with ranges from 0.5 to 1.8% of the population. The CDC found that 1.8% of high school students identify as transgender in 2017. A survey of over 3,000 high school students in Pittsburgh showed that 9.2% had a gender identity that did not fully align with their sex assigned at birth. For example, someone assigned at female at birth might be, they had the options of girl, boy, non-binary. And so this is obviously a much larger number than seen in prior studies. The questions here were more inclusive. Instead of saying, do you identify as transgender, the answer choices were select all that apply, and the options were girl, boy, trans boy, genderqueer, non-binary, another identity. So this may reflect the true prevalence of gender diverse people, or it might be a huge overestimation. Also, the fact that someone is gender diverse doesn't mean they have gender dysphoria, which is something to keep in mind. There isn't a lot of data about the prevalence among prepubescent children. Most studies show a prevalence higher in those assigned male at birth. However, there is some data which shows an equal prevalence between the genders. As far as the causes of gender dysphoria, no one knows exactly what causes it. It's thought to be an interplay of biology, the environment, culture, but no one knows specifically what causes it. Possible reasons you are your gender are people telling you what your gender is when you were little and you went along with it. Similarly, you matched your anatomy to the corresponding sex and gender and did what was expected of that gender. That sounds a bit simplistic, but it could be a factor. There are certainly biological determinants of sex, but there also could be biological determinants of gender. So I want to highlight a study that suggests a biological underpinning for gender. This is from the New England Journal of Medicine in 2004. Cloacal exstrophy is a rare, complex pelvic defect that occurs during embryogenesis. It's associated with severe phallic inadequacy or phallic absence in genetic males. For about 25 years, neonatal assignment to the female sex had been the treatment for these males to overcome the issue of phallic inadequacy. So this study assessed 16 genetic males in a cloacal exstrophy clinic from the ages of 5 to 16. 14 underwent neonatal assignment to the female sex. They were, raised female socially, legally, and surgically if needed. The parents of the remaining 2 children refused to assign them to the female sex. And detailed questions I evaluated the development of sexual role and identity. The results showed that 8 of the 14 subjects assigned female declared themselves male during the course of the study, whereas the 2 raised as males remained male. 5 subjects were living as females. 3 were living with unclear sexual identity, although 2 of the 3 had declared themselves male later. 8 were living as males, 6 of whom had reassigned themselves to the male sex. All 16 subjects had moderate to marked interests and attitudes that were considered typical of males. In the study, parents were instructed to avoid revealing information on their child's sex to anyone at any time, especially to the patient, and were told that such disclosure of their sex might harm their psychosexual development. The only 2 subjects who knew they were male were the 2 that were reared male because the parents refused to have them reassigned as female. So despite not knowing they were genetically male and being raised as female, most of the patients who were genetically male but assigned female ultimately declared themselves male. So this certainly seems to suggest that there's a biological basis for gender. This study that's highlighted here is a review on literature of case studies of twins concordant or discordant for gender dysphoria. Of 23 monozygotic female and male twins, 39.1% were concordant for gender dysphoria, which is quite high. And of the 7 opposite sex twins, all were discordant for gender dysphoria. So that seems to suggest a genetic basis. And another finding that suggests a biological basis for gender is what you see in complete androgen insensitivity. So these people have XY chromosomes, but their external anatomy looks female, and they're raised as female. These people are genetically male, but resistant to the effect of androgens. Most have female gender identity. It's thought that androgen action on the brain might be required for male gender identity. During early development, testosterone plays a role in sexual differentiation of the brain and has enduring influences on behavior. There are sex differences in the size, structure of numerous areas of the brain, including the bed nucleus of the stria terminalis, the INH3 nucleus of the hypothalamus, and other areas. So in transgender patients, the brain is more like the brain of the gender they identify with, regardless of treatment. The INH3 is significantly larger in males than in females, regardless of age, and larger in heterosexual males than in homosexual males and heterosexual females. So these are cell groups of the preoptic anterior hypothalamic area, which is a structure that influences gonadotropin secretion, maternal behavior, and sexual behavior in several mammalian species. Male to female transgender people have a size and number of neurons of INH3 closer to a normal female range, and female to male transgender people have a size and number of INH3 neurons closer to the normal male range. So the bed nucleus of the stria terminalis is a sexually dimorphic limbic forebrain structure involved in the control of male sexual behavior, gonadotropin release, and the modulation of stress and anxiety. So the principal nucleus of the bed nucleus of the stria terminalis is larger. It contains more cells in males than females of several species, including humans. So in rats and mice, sexually dimorphic cell death during the first week of human life can account for the sex difference in cell number seen in adulthood. And this sex difference can be eliminated by neonatal castration of males or treating females with testosterone at birth. And it's thought to be possibly due to epigenetic changes due to hormone exposure. As far as psychosocial factors involved in gender dysphoria, the formation of gender identity is thought to be influenced by the interaction of a child's temperament and parents' qualities and attitudes. Sigmund Freud believed that gender identity issues are due to conflicts experienced by children within the Oedipal triangle. Whatever interferes with the child's loving the opposite sex parent, and identifying with the same sex parent interferes with normal gender identity development, according to Freud. Psychoanalysts have postulated that the mother-child relationship in the first years of life is important in establishing gender identity. Father's role is also thought to be important. Retrospective studies in adult transgender people have shown differences in recalled child-rearing patterns between them and cisgender groups. Male to female trans people characterize their fathers as less emotionally available, less warm, more rejecting, and overly controlling. Female to male trans people characterized both parents as more rejecting and less emotionally warm, but they characterized only their mothers, not their fathers, as overprotective. In terms of learning theory, children might be rewarded or punished for gendered behavior, which may influence their gender identity. The course of gender dysphoria varies. Many children who exhibited gender nonconforming behavior do not grow up to be transgender adults. Children diagnosed with gender dysphoria do not necessarily grow up to identify as transgender. So retrospective studies suggest that gender dysphoria persists from childhood into adulthood in the range of 12 to 27%. There isn't a lot of data though, so there should be more, but these are the estimates now. Also, the children who do identify as transgender as adults have more extreme in their gender dysphoria and gender nonconformity as children. And many studies show increased rates of gay and bisexual identity among those who were gender nonconforming as children. So management of gender dysphoria involves supporting the individual's gender expression, psychotherapy, social transition, hormone therapy, gender-affirming surgery. The World Professional Association for Transgender Health standards of care are used by some clinicians as guidelines. I will cover the basics of medical management shortly, but I want to focus on the role of the psychiatrist in gender dysphoria. So our role is assessment, therapeutic support, managing psychiatric comorbidities, and providing letters and documentation if appropriate. In terms of assessment, there are many psychometrically validated assessments for gender dysphoria in children and adults. Examples are the Utrecht Gender Dysphoria Scale, Gender Preference Interview, Body Image Scale, and many others. A thorough psychiatric interview with diagnostic criteria in mind is required. So part of our role is providing therapeutic support. And it's recommended that you provide therapy to affirm their gender identity and not try to repair it. So managing psychiatric comorbidities is a responsibility. Some studies have suggested a link between gender dysphoria and autism spectrum disorder, with elevated rates of autism found in those referred to gender clinics. One study found 7.8% of those referred to a gender clinic met criteria for autism spectrum disorder. It appears there's some overlap or association between the two, but there's not a lot of information at this time. Gender dysphoria is associated with an increased risk of eating disorders as well. 20 to 30% of the individuals attending gender clinics meet the DSM criteria for an anxiety disorder. Depression and anxiety are common, and suicide and substance use are associated with increased depression. Studies have shown that substance use has been described as a coping mechanism for many transgender people to manage the enhanced levels of stress that they experience. Transgender individuals have a higher rate of lifetime suicidal ideation and lifetime suicide attempts. There's a wide range of prevalence estimates for depression in this population. I've seen estimates as high as 64.2%, while others reported ranges of about 31 to 36%. So if there are psychiatric conditions that impair a person's ability to consent or participate in aftercare, those conditions should be treated and stabilized first. Minority stress is likely a significant factor in the development of depression, anxiety, and other comorbidities seen in this population, because you see a reduction of these when they have a supportive environment. And treatment delays have been shown to increase the risk of developing psychiatric issues. Mental health professionals might be asked by insurance or surgeons to write letters prior to patients receiving gender-affirming procedures. So we can provide capacity evaluations, and the standard capacity rules apply here. And the APA has letter templates available online. In terms of medical management, in December 2020, the Endocrine Society stated there is durable evidence for a biological underpinning to gender identity, and that pubertal suppression, hormone therapy, and medically indicated surgery are effective and relatively safe and have been established as the standard of care. They noted a decrease in suicidal ideation among patients who have access to gender-affirming care and comparable levels of depression to cisgender peers among socially transitioned pre-pubertal youth. In its 2017 guideline on treating those with gender dysphoria, it recommends puberty blockers be started when the child has started puberty, which is at Tanner stage 2. They recommend cross-sex hormones be started at 16, but they note there may be compelling reasons to initiate sex hormone treatment before 16. They recommend a multidisciplinary team of medical and mental health professionals manage the treatment for those under 18 and recommend monitoring. The World Professional Association for Transgender Health published Standards of Care 8 in 2022. This states that puberty-blocking medication are medically necessary and recommends them for usage in transgender adolescents once the patient has reached Tanner stage 2. The WPATH Standards of Care states that psychotherapy should not be an absolute requirement for biological treatments. The American Academy of Pediatrics states that pubertal suppression in children who identify as transgender and gender diverse generally leads to improved psychological functioning in adolescence and young adulthood. In the United States, several states have introduced or are considering legislation that would prohibit the use of puberty blockers in the treatment of transgender children. The American Medical Association, the Endocrine Society, the American Academy of Child and Adolescent Psychiatry, the American Academy of Pediatrics, and the APA all oppose bans on puberty blockers for transgender children. So with regard to social transition, this might include changing a name, choosing a preferred pronoun, altering clothing or hairstyles, and adopting new activities. Now, medications that suppress puberty allow children and adolescents time to explore their gender identity without having to worry about ongoing pubertal changes and development of secondary sexual characteristics that might be psychologically disturbing for them. This can allow families time to access resources and support, and it can allow for time in which to explore the next steps. Suppression may occur at Tanner stage 2, which occurs on average at age 10.5 years in people assigned female at birth, and at 11.5 years in those assigned male at birth. This is the stage at which secondary sexual characteristics begin to appear. Gonadotropin-releasing hormone, GnRH agonists, are used to block puberty. These agents provide a release of a GnRH analog that leads to the inhibition of LH and FSH and reduced secretion of gonadal sex steroids. And There are alternative methods to suppress hormone secretion. These include anti-androgens such as spironolactone or cyproterone acetate, or progestins. Different medical regimens can be found in the clinical guideline from the Endocrine Society. Medications to suppress puberty, according to the gender assigned at birth, prevent further development of secondary sexual characteristics, even when puberty is underway or further along. After suppressing puberty, an adolescent may pursue hormone treatments to initiate the puberty that aligns with their gender identity. Those who didn't block puberty may also pursue hormone therapy like adults can. With regard to hormone therapy, hormones, which are testosterone for adolescents assigned female at birth and estrogen for those assigned male, promote the development of secondary sexual characteristics. So those who take testosterone should notice that fat is redistributed from the hips and thighs to the abdomen. The legs and arms appear muscular, brow and jawline would be more pronounced. The hair on the body should coarsen and thicken. And those who take estrogen would notice their hair softens and thins. Although many will still need laser therapy or electrolysis for adequate hair removal. One thing to note is that feminizing hormone therapy does not have any effect on voice, pitch, or character. Surgery is uncommon in patients under 18. Many children's hospitals and gender clinics don't offer surgery to minors. However, an analysis of insurance claims found 56 genital surgeries among patients aged 13 to 17 with a prior gender dysphoria diagnosis from 2019 to 2021. Among teens, top surgery was more common. And in the 3 years ending in 2021, at least 776 mastectomies were performed in the US on patients aged 13 to 17 with a gender dysphoria diagnosis, according to this analysis of insurance claims. So this number doesn't include procedures that were paid for out of pocket. Also, for this surgery data, multiple procedures on a single day counted as one procedure. With adults, there's no need for puberty blockers since puberty is complete. Adults are socially transitioned and treated with gender-affirming hormone therapy. In male to female individuals, original sex characteristics can be suppressed with LH agonists, progestational compounds, spironolactone, flutamide, and cyproterone acetate. Breasts, increased body fat, and a more feminine body shape can be promoted with ethinyl estradiol and conjugated estrogen. In female to male individuals, facial and body hair growth may be promoted with testosterone. In addition, surgery may be pursued and is more accessible to adults. Surgeries are not required for gender affirmation, but many choose to undergo them for a more complete transition. There are masculinizing and feminizing surgical options available. For masculinizing, you can have chest reconstruction to remove breasts and phalloplasty. This procedure can include removal of the vagina, reconstruction of the urethra, and penile construction. Surgeons might use either vaginal tissue or tissue from another part of the body to construct the penis. Facial gender surgery can include a series of procedures such as forehead lengthening and augmentation, cheek augmentation, reshaping the nose and chin, jaw augmentation, and thyroid cartilage enhancement to construct a visible Adam's apple. Feminizing surgery might include vaginal construction, and patients can get breast augmentation and facial procedures to create more feminine features like reshaping the nose, the chin, the cheek, and the jaw. They can have an Adam's apple reduction and an earlobe reduction. Most of the studies I've seen show a very high rate of satisfaction among patients who underwent these surgeries. So estrogen therapy for transgender women can cause diminished sperm production and lead to azoospermia. Similarly, transgender men undergoing testosterone therapy may experience amenorrhea and impaired fertility. So there are options available to preserve gametes and gamete materials that would otherwise be adversely affected as a result of transitioning. These include sperm banking and cryopreservation and testicular or ovarian tissue banking. So that's all I have today. Thank you for attending. Does anyone have any questions? So you're asking about the risks of, yeah. So risks of puberty blockers.
Yeah.
Okay. So one concern with using GnRH agonists is their potential effects on bone health. So available data on adolescents who have been administered GnRH agonists show that bone mineral density of treated youth decreased during therapy when calculated as an age-based Z-score. So a recent study showed that the bone mineral density was below their pre-treatment potential, and that attainment of peak bone mass had been delayed, or peak bone mass itself was reduced. However, another study found that the subsequent administration of cross-sex hormones substantially increased bone density back to the appropriate level in both the genders or sexes. So that's one risk. So puberty blockers typically are being used for like 1 to 2 years, and then the sex hormones will take over after that. So once the sex hormones have their effect, it's reversible. But I haven't seen a lot of data as to what happens if you prolong the GnRH agonist treatment for beyond 2 years. Probably it would have a detrimental effect on the bone density. Thank you. Any other questions?
Yeah, I'm really interested in this topic and maybe the comprehensive. My question is, if the gender dysphoria is decreasing every year, and so the professional disagreement on this, it's not that people are coming out, or it's, you know, the gender dysphoria, but the people who tell the gender dysphoria. So I'm sure you have studied much more on this, and I've not had that chance. Did you find any study that like was so like 60s full of people with identifying themselves with another gender, even though they don't have gender dysphoria? And then the parents are worried about it, how to, you know, how are we as professionals supposed to respond to that? And then are there any studies identifying, you know, what is the percentage of you know, not true gender dysphoria in all of these? If they say that a lot of people, but because they are now given medical treatment, you know, behind gender, even when they are minor, and a lot of them may not be, you know, they do not have true gender disorder. So how do we handle that?
Yeah, well, that's like the $1 million question. And that's what's causing a lot of the disagreement among professionals is how do we do that? I mean, I touched on the prevalence earlier. I mean, there isn't a lot of data, like this whole subject is kind of in its infancy, but most of the prevalence ranges are from 0.5 to 1.8% of the population. And as far as how many kids will have gender dysphoria later on, or like stable, different gender identity, I think I touched on it, but we don't have a ton of data, but it's about, there's not enough data to say like exactly what are the percentages. One thing is with puberty blockers, usually they use it for 1 to 2 years. And if you stop the puberty blocker, the puberty will resume once you stop it. And puberty blockers are the treatment for precocious puberty. So if you administer puberty blockers for like 1 to 2 years, and the child has a stable, gender dysphoria, you can initiate cross-sex treatment. In that time, they might not have, they might identify with their assigned sex in that time, at which point you can just stop the puberty blockers and their normal puberty will resume. So that's not really harmful. Yeah, thank you. Any other questions?
I think that you did a fantastic job today, and welcome to the faculty. There couldn't be a hotter topic for discussion. I don't think couldn't think of anything that's a better topic right now than gender. Good job.
Thank you, Dr. Lipman. And Dr. Casey.
So not questioning, you perceive a shift in the last, say 5 or 6 years, even since I've been in attending. Initially, when people would come to me, they were quite confident. Transgender. They'd say, I was born this way, and on the other side of it, more in the wrong body, and they were sure. Now, many people come to me, and they're often in praise that they are trying on different genders. And they identify as transgender as its own unique thing, as opposed to I'm on the other side. It's I'm in the middle. I'm not binary. And many of them have had no gender dysphoria as a child, or say that they were able to hide it so effectively that everyone knew about it. But it's very different than what I was hearing just 5 or 6 years ago. It's gone from kind of I was born this way, so I'm going to choose to express myself in various ways.
Yeah, and I think that study with the Pittsburgh high schoolers, where 9.2% of them, had that kind of identity, highlights that. So yeah. So thank you. Any other questions? All right, if not, thank you very much for attending. Oh.
Yeah.